Hello, and welcome to Let's Talk Live SADS Canada. I'm your host, Dr. Shubhayan Sanatani, and I'm coming to you from Vancouver, British Columbia. And we have a wonderful show today, a little bit different than our format with a question and answer period. So much more interactive, especially since you, our audience, have submitted questions. And I had a chance to look at the questions. The questions are fantastic. So I'm very excited. As you know, this is a place where we come together to learn from each other. And I'm very privileged to be the host of that. And really, the conversations so far have been so interesting. I'm probably just the person that pushes a snowball at the top of the mountain and it just goes on its own and gains momentum. So that's definitely a Canadian analogy. And so excited to be here for episode 15. We're almost halfway through Heart Month. And of course, February is Heart Month. And this year we have an extra long February with the 29th. And so one of the things I'm really excited about, some of you will recall we had Christina Bangma on our show last year. She is, of course, a patient and a thriving patient with arrhythmogenic cardiomyopathy. And we talked a bit about her book, which is a really great read, Athlete at Heart. She was a high-level competitive cyclist and literally collapsed on the bike. And her journey is a great read. And she has very kindly agreed to contribute $2 from the sale of every copy to the SADS Foundation. And so definitely the link is there, and it's also on the website. So please pick up a copy of her book. It's a nice gift as well. So for some of you who have inherited arrhythmia conditions, SADS conditions, a lot of information in this book to help you and also help your family and your loved ones. So I highly recommend it. It was a great read. So thank you, Christina, for doing that. That is very generous. I always like to take a minute because I'm not paid to do this. I'm not on commission here, but I like to speak to the fact of why I come on here and talk about money. Even this webcast, paying the fees to have this going. We have a wonderful tech support in Evan Kruger, but everything costs money these days. And so the SADS Foundation, Canadian SADS, is always very grateful for your support. Even a small amount goes a long way to help us keep bringing you our programs and advocacy. And I think we're working on a in-person meeting. I keep saying that, and our executive director, Pam Husband, she's probably rolling her eyes right now because it's a lot of work that I keep making her do. So in 2023, I did what a lot of Canadian trivia, with a lot of medical trivia, a lot of black and white photos of historical things like the first nurse in Canada, the first female physician, things like that. So this year we're changing it up a little, and we're teaching you about SADS conditions, so sudden arrhythmic death syndromes, so things that cause sudden death in young, otherwise healthy people, and often these things run in families. So this is definitely a family program. Last month, I introduced this fun bit of trivia. Bidirectional ventricular tachycardia can be caused by digitalis digoxin, which of course is a very old drug. And so this month's fun fact, or did you know? Oh yes, did you remember that you already knew this? So today, I really do like the history stuff. So did you know this is a photograph? No, it's not a photograph. Sorry, a painting of Lancisi, who was the Pope's physician in the late 17th century, who died early in the 18th century. And this book, De Motu Cordis, is essentially things that he learned from patients and deceased patients, including the Pope. I will confess I have not read this book. And the fun fact is that arrhythmogenic right ventricular cardiomyopathy, or ARVC, was actually first described about 300 years ago in this book. And so one of the first descriptions of this. So even though we sometimes talk about it and it feels like people don't know about it or haven't heard about it, it's actually been around a very long time. And so, and then people might wonder, why are we learning these weird facts? At the end of the year, we'll try and put on a little bit of a fun contest. And last year we had someone win $200 in a gift card. And who knows, maybe this year we'll even up the ante. So we're going to talk about arrhythmogenic cardiomyopathy next month, and we're also going to talk a little bit about a new trial of a therapy. So one of the roles we have at the Canadian SADS Foundation is, of course, to stay apprised of new developments and research and collaborate with researchers. So Dr. Jason Roberts is leading this study on a new molecule. And so more about that, and there's a little bit of information on the website. So certainly if you have arrhythmogenic cardiomyopathy and want to learn a bit about this, get some information, talk about it with your genetic doctor. So delighted this month to have a special guest. Dr. Ciorsti MacIntyre is a genetic expert, did her initial training at Dalhousie University before going to Brigham in Boston, where she did a fellowship in electrophysiology, and then did additional training in inherited arrhythmia with none other than Mike Ackerman. I always like to acknowledge the support of the larger U.S. SADS Foundation, Alice, Lara, and Aaron, and of course Michael Ackerman himself have really been huge supporters of ours and helped us launch this program. So Dr. MacIntyre spent some time there, and in fact went and worked as an attending physician there. But ultimately, the draw of Canada was too strong, and those maritime winters, I think, brought her back. And so delighted to have in studio today Dr. MacIntyre, who's going to help me tackle these questions, because certainly I would not want to do that on my own. So please welcome Dr. MacIntyre to the studio.
Thank you so much for having me. It's great to be here.
Well, and thank you for reorganizing your day. I hope that your staff is watching this or watches this on the recording. These are, of course, available later to be streamed, and so then they will see that you are in fact here for a legitimate reason and not just messing up their day. Exactly. And I'll apologize in advance, because I will flip back and forth sometimes between calling you Dr. MacIntyre, which of course is how I should address you all the time, and Ciorsti. I have the privilege of having a friendship with Ciorsti, and she was very kind to also include me on a recent very important publication about long QT syndrome, some practice guidelines. So that's a very important document where we really updated and brought to the general practitioner, the internist, the family doctor, some really practical points about long QT syndrome. So if you look up Dr. MacIntyre, you will find that. So you and I talked a little bit about this and how excited we were, and we saw some great questions. And I'm going to just try and go in a not random manner, but in a somewhat systematic fashion. But some of the questions really clustered around devices. And so I'm going to start us off with devices. And so the question reads here: in many SADS conditions, an ICD is implanted as an insurance. And so ICD, of course, implantable cardioverter defibrillator. And the person is curious about device failure. And so before jumping into device failure, which of course is a thankfully an uncommon event, maybe just walk us back a minute and give us a general overview of what is even an ICD, what are they, what can they do, what don't they do, why are they implanted, and then of course, what are the shortcomings?
This is such an important topic, and I'm so glad that it was brought up, because discussions around device therapy in our patient population is so important. So for those of you who aren't familiar, a defibrillator is an implanted device. It goes in kind of like a pacemaker. So we'll insert a wire in through the bloodstream down to the heart, and it gets attached to a little gadget we implant under the skin. And it can do all the same things that a pacemaker can do, but more importantly, it's also able to recognize dangerous heart rhythm problems and treat them with shocks, like the paddles on television that you see, but from inside the heart. And one of the challenges, one of the hard parts about our job, is figuring out who does, and more importantly, who does not require a defibrillator as part of their treatment for these really important conditions. And I think one of the most important concepts is that the majority of patients with SADS related conditions don't require a defibrillator as part of their treatment program, but there are certainly patients who do. And one of the challenges is that a lot of our patients are quite young. So we're expecting people to have long lives with these conditions. So that means that a person who receives a defibrillator at a young age might have multiple change out procedures over the course of their life, which increases the likelihood of complications. And on average, the battery from a defibrillator will last about a decade. The wire that goes into the heart typically lasts a little bit longer. So we're very careful about who we choose to implant a defibrillator in the first place. And you might say, well, why doesn't everybody just get a defibrillator? If it can be like an installed paramedic, shouldn't we all have one? And that might be true if they were without risk and without complications, but for certain conditions, there's particular thoughts and nuances that go on to thinking about it. And then there's also the issues that go along with having an implanted device in your body, because a significant number of patients, especially our younger patients, can have problems over time related to the device. So in terms of the sorts of issues that a person can have, you can kind of think about them as procedure-related complications or more longer-term consequences of having hardware inside your heart, as well as treatment-related issues. And if we think about things like the sorts of complications that you can get infections of these devices, you can have pain at the site where they go in. When we implant the device, some people can have a hole in their heart, a perforation, or a collapsed lung that we need to deal with. They're also machines made by people. So over time, there can be wear and tear on the different components, and the leads can fail, they can fracture, which poses complications to how we manage things moving forward. And there's also the whole concept of inappropriate shocks from the defibrillator. So sometimes devices aren't perfect. So you might get a shock for a rhythm that wasn't dangerous, that was never life-threatening, where you might be wide awake for the event. And that's not a pleasant experience for patients. The more shocks a person has, the more depression we can encounter. And in some conditions, the adrenaline surge related to the defibrillator shock itself can potentially be problematic. So about a quarter of patients with these devices can experience an inappropriate shock. And in some studies, they've shown that about 30% of patients can have some type of device-related complication over the course of their lives, which is really a significant number of people. So we need to be good stewards of this type of therapy to make sure that when we put in a defibrillator, we're thoughtful about the indication and make sure we're making good choices.
Yeah, thanks. And as we're talking, I'm realizing we could probably do a whole segment on these devices. I mean, thankfully, the device itself, the computer, is very smart, and it's almost never the issue. It's almost always that the lead, as you say, and there are some devices that don't even have a lead inside the blood vessels now. But the lead is really the Achilles heel of this system, and getting shocks when you don't need them. So yeah, wonderful. And then this sort of dovetails into sort of a part B. Someone asks, their device is under recall, and that's a sort of a worrisome thing. I always think of cars and airbags going off and things like that. But I mean, you and I have encountered so many of these, initially infrequent events, but now it seems like every week there's a letter from, one of the companies saying, we found something. Take us through a little bit of that. What are these people really finding, worrisome things? And, does one have to panic and get the defibrillator taken out for most recalls or advisories?
So I try to call them advisories because I feel like recall often sounds like, oh my gosh, are they going to have to replace the airbag in my car or replace my device? And the good news is that most of the time that's not the case. So pretty much all of the major device companies have had recalls in the past and will have recalls advisories in the future. It's kind of the downside of technology. So no technology is perfect, and there's multiple components to a device. So there's batteries, there's the components of the device itself that provides the therapy, and like you said, there's the wire that goes into the heart, and each of those can have issues. So we've certainly seen advisories related to less than stellar battery performance, where some people may have early depletion of their battery. We've seen issues where certain types of wires that go into the heart may be more prone to breakage over time. And then one of the newer advisories that some of you may be experiencing yourself is an issue where certain devices were seen to not reliably deliver therapy. Now, the good thing is that for most advisories, we're able to come up with a fix, a patch, some solution that allows us to either just follow you more closely so that we have, a knowledge of when to intervene sooner. And that's been really helped by things like remote monitoring, where you have a device beside your bed. So we have very quick identification of issues when they arise, but also they're able to develop workarounds for the problem so that most of the time we don't actually need to operate in order to fix an issue. So there's a whole advisory board within Canada, within the heart rhythm community. So there's a group of physicians that are on all of the alerts that come through so that they can be communicated to the different clinics. And then typically patients will be advised as well, typically through their own clinic, but often from the company as well, so that they're aware that this issue is going on so that their issue can get addressed. So it's one of the inevitabilities of technology, unfortunately, but there's a huge commitment to ensuring that our patients stay safe and that their devices stay safe and functional moving forward.
Yeah. No, thank you. I think a couple of points. The devices are, of course, rigorously tested well before they reach people, but the numbers that get implanted, then suddenly, the 99.9% success rate then might reveal in 100 people out of 800,000 or whatever. There's an issue.
Yeah, even if you're part of an advisory, it's such a small proportion of the devices on advisory that actually have a problem to begin with. So typically we're able to identify what that percentage of risk is. And the good news is it's usually a very, very, very small number of the people who get the letters. So the overall risk is fortunately very low, especially when you come to clinic and come to your appointments and are able to have those patches and fixes put in place.
And I think, we'll put a plug in here. Before we started, Pam husband was talking a bit about maybe a session of, what sort of patient should I be? Definitely, if you have an implantable device, pacemaker or a defibrillator, definitely attend your clinic regularly, even if it feels like, they're always just telling you things are fine. That is a very important point of contact with healthcare, because they may add a software upgrade that, fixes a problem and prevents it from happening. So very, great question. And obviously a very informed audience. Let's change directions a little bit here. And I'm always grateful that our audience doesn't tend to ask for a medical second opinion or go through, why their Uncle George hasn't seen a doctor yet. So thank you for that, because we can't really delve into that. But, here's a question that really, I think, is excellent. So this individual writes, I suffered 3 cardiac arrests, quite recently, and no known cause to date. And the individual wants to talk about genetic testing. So I've requested genetic testing from my cardiologist, but he doesn't seem enthusiastic. So I'd like to break this down because there's a lot in this question. So first of all, let's talk a little bit. Yeah, let's talk a little bit about this concept of having a cardiac arrest and there's no obvious explanation, because as you and I know, that's a fairly common situation. So take us through a bit of that.
So it's a great question, and we're fortunate to live in Canada because this is a topic that those of us that are very interested in these topics and genetic heart disease and cardiac arrest have delved into as a country. So Canada's been really, really important in terms of trying to define this particular problem, because when people have a cardiac arrest, a lot of the time it's because there is something identifiable or structurally wrong with the heart. A heart attack would be an example where you get a blocked artery and the heart can develop a dangerous rhythm. But there are certainly some people who have a cardiac arrest, they're resuscitated, but then their heart tests look pretty good. And the reason for the cardiac arrest isn't immediately apparent. And the first question I always ask in this scenario is, okay, well, what do we mean by an unexplained cardiac arrest? Were the tests that we would traditionally advocate for as part of the Canadian genetic heart rhythm community done? Because that's often the first challenge. So, when we think about the common things being common, very frequently people will have either cardiac catheterization, so an angiogram or a CAT scan looking at the heart arteries to look for blockages. So we would expect that to be normal in a scenario like this where no cause is found. And people will typically have an echocardiogram or even an MRI to look for structure reasons that the heart might be more vulnerable to these dangerous heart rhythms. And in many circumstances for patients who come through my clinic, that's often where the thinking stopped. But there are more tests that can be done, things like an exercise stress test on a treadmill, where we can see if there might be some irritability in the heart rhythm, like a condition like catecholaminergic polymorphic ventricular tachycardia, where we expect certain findings in that scenario. Or we might see that the QT interval behaves abnormally on an exercise stress test in a diagnostic way that might not be immediately apparent in the electrocardiogram. But there are certainly times where people go through every test that you could imagine and the heart still looks pretty normal, but somebody had a cardiac arrest. And that's when we were in this category of unexplained cardiac arrest. And I think most of us would have a few different approaches to that. So the next step for me when I see folks like that is to look at their family members. So if I look at your first degree family members, so your kids, your siblings, your parents, can we pick up an abnormality on their testing that might give us a clue? When all of that's negative, at times I will consider genetic testing, but the yield, so the number of times that testing comes back positive, isn't very high. And one of the challenges with genetic testing is not the doing of the test. The doing of the test is simple because we can do it through spit or through blood, but it's the interpretation of the results that we get back and making sure that we don't overinterpret results that really aren't prime time, that aren't ready for kind of diagnosis. So you want to make sure that if genetic testing is being pursued, that it's being pursued with thoughtfulness and by a person who's used to studying those types of results. Because the only thing worse than not having genetic testing when it's indicated is having genetic testing that isn't interpreted appropriately, because that can have a ripple effect, not just for the patient, but for their family members if they end up with a diagnosis or a treatment that may not be relevant purely on the basis of a genetic test result. So we want to use genetic testing responsibly and wisely, and that's why we're so lucky to have a genetic network in Canada where we think about these things a lot, because oftentimes it's not clear, and we need to kind of be careful in our interpretations moving forward. Not sure what your experience has been, but it's certainly been mine on the adult side in this area.
Yeah, I'll do a couple of shout outs. People, might remember we had Melanie Kerr as a guest. She did back-to-back education episodes, teaching us, first of all, a bit about the language of genetics, and then also talking a bit about exactly what you're talking about, what our good friend, Dr. Ackerman refers to a genetic purgatory, where you didn't do the test properly, and then you're stuck with the result that you don't know what to do with. And so absolutely. We are very fortunate in Canada to have a good network of genetic counselors and a network of physicians. And another shout out to Dr. Andrew Cron, because I think we're approaching about 20 years in terms of when he had the vision to start the registry. Back then it was called CASPR, the Cardiac Arrest Survivor Registry, where it wasn't the usual cause, quotes, a heart attack. And so I think that actually connected a lot of us and let a lot of us get to know each other and really strengthen our community. I'm gonna pull out another sentence from this wonderful question. The person has written, the doctor doesn't seem overly enthusiastic, and so I can't emphasize enough that it's very important that, if possible, that you're dealing with someone who is a SADS expert. And Canada is geographically large, but the network of individuals is very small. And this, and the SADS Foundation, the Canadian SADS Foundation, has a role absolutely in connecting people and saying, have you gone to this clinic and that clinic? And I think that's very important.
And in Canada too, not everybody can order genetic testing. So we do keep tighter reins on who has access to ordering genetic testing in Canada, which is different than in the United States, where more people can order it. But again, the same realities exist in terms of the challenges of interpretation. So, we frequently see patients with unexplained cardiac arrest in our genetic heart disease clinic, not necessarily because the problem is genetic, but because we want to be able to pull from those areas where maybe it's genetic, maybe it's not, but to try to come up with a diagnosis, or to give every chance we have to come up with a diagnosis before we'll say that it's unexplained.
Absolutely. And the finding of a genetic variant has to be interpreted, very cautiously with all the SADS conditions. And so we in our program don't tend to encourage people just doing, the sort of direct to consumer where you might, be approached by a genetic company directly, or, things like Ancestry and, other companies, because they sometimes lack that sort of that additional, interpretation of the clinical picture and the genetic information. So yeah, so it's all of us have had to learn about genetic medicine as part of becoming a SADS specialist. So I had mentioned ARVC, arrhythmogenic right ventricular cardiomyopathy. So I'm going to ask you a hard question here. Let's start with, what are the best practices for monitoring progression of ARVC? So this individual presumably has been told they have a risk for it, or maybe they have a genetic risk, or maybe they have a relative with it. So what do you tend to do, and how often?
It's a really great question, and it can be a tough one too. So in the same way that having negative genetic testing does not mean that you don't have a condition, having positive genetic testing, so testing positive for the disease-causing variant in a person's family, doesn't necessarily mean that they'll show evidence of the disease in their lifetime, but they're definitely at an increased risk of developing that condition, whatever it may be. And ARVC is a good example of that. So we can see people show signs of ARVC at different points in life. So, one person in a family might present early and have signs at 20, whereas another person might not show signs of it on their testing until they're in their 40s or 50s or 60s. So one of the things that's really important, especially if we know that a person carries a genetic variant in their family, is periodic evaluation. It's not a one and done situation. So when I see patients and they come to the clinic for their screening, an electrocardiogram is one of the tests that we order, and there can be certain changes on the electrocardiogram that evolve over time to be suspicious that the heart may now be showing signs of the condition. A Holter is part of it. So that's one of those recording gadgets that you wear for about 24 hours to count up your heartbeats over the course of 24 hours, because one of the early signs is we'll see more skipped beats from the bottom chamber of the heart when ARVC is starting to show itself. And then imaging is an important component of that as well. So an echocardiogram shows us the heart structure and the strength of the heart. And periodically a cardiac MRI can be useful as well. So typically when I'm seeing people who have a family history of ARVC and they carry the genetic mutation, I'll see them every 2 years or so with an ECG, a Holter, and an echo, and then periodically an MRI to have slightly clearer picture, since the right ventricle of the heart is a little harder to see on echo. And in terms of differences within that, so if a person has a symptom change in the meantime, so in the couple of years between visits, then I'll see them sooner. And also if there's something particularly more high risk about a patient, then that may change the frequency. So there's certain genetic variants where, like the Newfoundland variant, TMM43, where I'm more concerned just by the presence of a genetic test, that would change my approach. Or if a person is a competitive athlete, especially if they do endurance sports and they've chosen to continue to do endurance sports, I might see them more frequently, given that can accelerate the onset of changes from the condition. So there's certain patient factors that may influence the usual protocol, but that's the norm for our clinic here in Halifax.
Yeah, and the short answer is it completely depends on so many things, and I think the main thing with ARVC, arrhythmogenic cardiomyopathy, is especially if you had an evaluation when you're relatively young and you truly have a family history of it or a genetic risk, it's not one and done. You do need ongoing follow-up, and it can evolve. Next month we're going to have Kathy Hodgkinson from Newfoundland, so we're really going to drill down on the Newfoundland variant and uncover that a little more. You mentioned the right ventricle, so I'm gonna jump to this again. I can't say enough about the quality of these questions, so thank you. This individual has written, can ARVC affect the left ventricle? So even though the right ventricle is in the name, this person has very astutely said, can it affect the left ventricle, and does it change the management? So
great question. And I think our understanding of what I would call the arrhythmogenic cardiomyopathies has really grown over the last number of years. So, previously we used to think about ARVC being a right ventricle problem, but I think we've all realized that, while for classic ARVC, the right ventricle may be the most involved, for some of these conditions, the left ventricle can be involved, and it's very important in terms of the types of medications that we may use, and it factors into our decisions around device therapy as well. And part of it depends too on sometimes the genetics are a little different. So depending on the genetic mutation, that may alter whether we're expecting to see more left ventricular involvement. But we certainly don't ignore the left ventricle in our patients, and we keep an eye on it. And certain conditions are more likely to involve the left side, the right side, or both, depending on the specific scenario.
So I've just put up a slide from this is a pediatric paper, and really just showing right ventricle is the blue circles, left ventricle is the orange, and then both ventricles is the rainbow at the end. And really what we've learned over the years is that the left ventricle is often involved, especially as we follow these folks along further, and it definitely influences how you follow them, is really influenced by their genetics. So as I mentioned, we'll talk a bit more about ARVC in detail next month, but great question, and definitely affects the condition. I noticed a couple of people have some follow-up questions about the defibrillators in particular, and I'll just say, are the risks the same for the subcutaneous ICD? So this is one that it's technically not leadless because there is a wire from the device, but it's not in your bloodstream. So it's still kind of, it still has a lead, but the lead is not as as prone to movement. And I would say that the risk, is fairly early days, especially in the SADS conditions. But what's your experience and learning been?
Yeah. So the subcutaneous ICD, so the one without hardware inside the bloodstream, inside the heart, is a really great option for some patients. There's pros and cons, like everything. So in people who have no indication for pacing whatsoever, because it can't do the pacing therapy that a defibrillator can do, and in people who are more prone to the very fast, disorganized rhythm ventricular fibrillation, where the shock is going to be the treatment as opposed to the painless therapy that a defibrillator in the blood vessel can provide, called antitachycardia pacing, because the subcutaneous ICD can't do that. Painless therapy can really only do shocks. And if a person has a really normal electrocardiogram, then I will often think of that as an option, because there is an attractive quality to keeping things outside of the bloodstream, not crossing any heart valves. The downside is, like you said, they haven't been around as long, so we don't know the track record as much. The likelihood of an inappropriate shock, so a shock for a non-dangerous heart rhythm, is slightly higher. It's gotten better over time, but it is slightly higher, and it can't do all the same things. So if a person also needs a pacemaker, or they're likely to need the pacing therapy, the painless therapy for dangerous fast heart rhythms, then that wouldn't be the option to choose. There's also a screening program, and a person has to screen in. So there's certain criteria on the electrocardiogram that they have to fulfill to make them a candidate for it. So it's a little more picky in terms of who it's a good option for, but it's certainly a great option in people where that makes sense and their clinical profile fits with a subcutaneous ICD. They're quite big, so I find a lot of petite people sometimes find them uncomfortable, because unlike the traditional defibrillator that sits up in the chest, the subcutaneous ICD, the generator, so the can goes in the armpit area. So if a person's very petite, they may find that they hit it a lot, and they're quite a lot larger than a traditional defibrillator. So there's a number of factors, and that's the sort of thing, the pros and cons of each are the sorts of things that we talk about with folks in a shared decision-making type of conversation before a defibrillator is implanted, in terms of what the best option is. And as leadless technologies like leadless pacemakers and whatnot emerge over time and become more integrated with defibrillator therapy, who knows what the options will be. So I anticipate that our device realm will look very different 10 years from now than it does today.
Yeah, the technology is evolving. The components are getting smaller, and we've seen quite an evolution. So yeah, I'm gonna jump back to a clinical condition. It's one of the ones that I see a lot of young people with this. You had mentioned it, CPVT, catecholaminergic polymorphic ventricular tachycardia. It's a real mouthful, CPVT. And this person has asked, given that it's the adrenaline that brings on the arrhythmia, is epinephrine still considered the frontline agent in an arrest, or would it make things worse? And so let's presume that the person is known to have CPVT, because of course, if you don't know that they have CPVT, you're gonna do the standard things that any emergency department would do. So you have the thankfully relatively uncommon situation of someone who is known to have CPVT or a genetic risk, and they've come in with an arrest.
It's a really challenging question, and when I heard about that one, I thought, oh, that's a tough one, because my first priority when I'm dealing with a patient who's had a cardiac arrest is to get them back, and doing any means necessary in order to accomplish that. And if there are times where we need epinephrine to try to do that. So I think a lot would depend on the scenario. If it seemed like we were in a situation where we were having, bad rhythm after bad rhythm after bad rhythm, then I probably would stop using adrenaline in that scenario. But in the original resuscitation efforts, I probably would continue to follow our normal protocols, knowing that this is a really tough area to study. So if we look at our advanced life support protocols, they're based on all comers with cardiac arrest, and they're not nuanced for are rare genetic conditions that might affect 1 in 20,000, 1 in 10,000 people in the population. So I'm curious what your perspective would be on this one, but it is not something that I would typically avoid in a cardiac arrest situation. Totally different than if a person's having episodes of arrhythmia up on the floor. That would change my approach, or if they were having recurrent defibrillator shocks, my approach would be very different. But in a classic arrest, I would tend to follow the normal resuscitation protocol. So I'm curious what your insight as one of our leading experts in CPVT would be.
Yeah, it's again, it's always important for me, for you and I to step back and think of, the frontline care providers. And these are these poor, emergency departments that are in our newspapers every day, it seems. And so what they're seeing mostly is, older people with some form of heart disease that is not CPVT. And so you want them to respond quickly with what they know and do what they know. So it's really, it takes a lot of good fortune to turn the momentum and say, actually, what we're doing isn't working, but here's the reason. So, I mean, sadly, the outcome of a cardiac arrest is very, very poor. So I'm always amazed at how many people in the chat or, in our meetings say, well, I survived a cardiac arrest, because they're a statistical improbability, as much as I hate to say that. Now, we know that AEDs and CPR are life-saving and can really change the odds. So I digress. I have been in a situation where I was able to talk to the emergency team who were struggling with the resuscitation and change the direction and say, the epinephrine's not helping and the shocks are not helping. The repetitive shocks and the epinephrine were driving the adrenaline, exactly as our question asker has said. And we had to then stop everything and very counterintuitively give beta blocker, which is, but again, it takes a lot of fortune. So if what's the takeaway here? If you are a SADS patient that has CPVT, one of the most protective things is following your team's instructions. So take your medications and, take your medications regularly. That looks after about 90% of the problem, because the medications for CPVT, thankfully, are very effective. Work with your genetic expert team. Carry something on your person that identifies your medical condition. So our phones are smarter than most of us now. There's an emergency thing. If it says I have CPVT, I had one patient, he actually got a tattoo on his wrist saying, don't use adrenaline. And so you can help the healthcare team.
Sure. Well, I think the challenge is you and I aren't the ones responding first line to the cardiac arrest to be able to change the normal course of things. So I think one of the keys in medicine is, when it's not working, when what you're doing isn't working, is to think about it. Because as much as you and I think about CPVT a lot and the treatment of CPVT a lot, other people are thinking about a lot of other disease processes and don't know the nuances of these rare diseases. That's why we have specialized clinics. So I think it's great that they were able to pick up the phone and call you and have a meaningful intervention, because at the end of the day, it's not going to be you or me thinking about it in the heat of the moment. We get called after the fact often. So it's a really important topic, but the majority of cardiac arrests are not related to CPVT. So it's tough for us to say that epinephrine shouldn't be part of the resuscitation algorithm, even though for a particular individual with a known condition, it can be problematic.
Totally agree. And of course, one of the roles of the Canadian SADS Foundation is, advocacy and, support the families and provide them with tools and knowledge. So, I can't believe it. We're at time here, and we've just sort of barely scratched the surface, and there's great questions in the chat as well. There's some questions around Brugada syndrome. Like, I do know we have a Brugada session coming up in the spring. Ciorsti, Dr. MacIntyre, we're clearly going to have you back to finish off some of these questions, which are great questions. And I really appreciate you being here today. And it's definitely, you bring an excellent perspective, not only as a, as an adult clinician, as a genetic expert, also as someone who has worked in both Canada and the States. So loads of practical experience. And anyways, thank you so much for joining. And I hope your team is okay that you've done this in the middle of your day. Thank you.
Thank you so much for having me, and I'd be thrilled to come back. So this was a wonderful experience, and thank you for the invitation.
All right. Well, great. And thank you to our audience and our families and our healthcare providers who, ask these great questions. And I always learn from the questions. And so Evan Kruger and Pam Husband and I are gonna put our heads together and figure out how we're gonna look after the other half of the questions that we didn't get to. And I see great ones in the chat as well. So but again, we are at time. I really thank you for your support. Think of those. Keep thinking of those questions. Remember our fun facts. I'm looking forward to seeing you next month, where we're going to talk with Kathy Hodgkinson about arrhythmogenic cardiomyopathy. So for now, that's it. And remember to